We're really pleased and honored today to have Dr. Kurt Olding with us, who's going to present a very interesting case that has a lot of repercussions for your clinical practice. So hopefully there'll be a lot of questions that pop up as he does the presentation. Dr. Olding is a graduate of my alma mater, National College of Chiropractic. He graduated in '84. He's also a primary spine practitioner from the University of Pittsburgh program, and a diplomate of the International Academy of Neuromusculoskeletal Medicine. He is an instructor and has been for a number of years for Cox Technique seminars with Dr. James Cox, and has been teaching around the country pretty much for the past several years. He has several publications to his name and has been involved as a lead investigator in a clinical trial with Dean Smith and Catherine Pullman, Dean at Miami University and Catherine at Parker University, investigating Cox flexion distraction technique. And so without further ado, Kurt, we'll turn it over to you and let you present the case.
Thank you, John, for the nice introduction. Okay, I presented this case to John because I thought it fit nicely with the PSP program and the necessity to have spine care specialists to be the portal of entry for many of these problems, because I think this is a perfect example of a case that could have gone really wrong if it hadn't been handled properly with it. So I thought this would be a good case to go through, and especially with a case like this of a Tarlov cyst, which I was trained 40 years ago. I've been in practice for 40 years that they meant nothing. And as you'll see on some of these reports, there's often still said that incidental finding that you'll see on your MRI reports. So I think it's an important case to go through and look at just to see what to look for and what we might see with these cases.
If you just click on over to the left there. Oh, there you go. Perfect.
Okay. Okay. This particular patient was a 48-year-old male, had an 8-month history of back pain and sharp burning pain in the right heel. He initially saw his podiatrist and he had a cortisone injection, which did give him relief for about a month. The burning pain returned, and at this time, it was in both feet and was progressing distally across the bottom of both feet, much worse when it came back, and now in both feet. It was kind of interesting, his presentation. When this first started, his pain was relieved almost totally by lying down, and it would worsen when he would go from laying to sitting and also from sitting to standing. As this problem progressed over that history of 8 months there, he started to develop where sleeping was difficult. The burning in the feet just didn't allow him to sleep well, and his sleep was really suffering. He rated his back pain initially as 2 to 3 out of 10, very mild, nothing major for him. It really wasn't why he came in. He came in because of his foot pain and burning, and he rated that as a 7 out of 10 on his initial visit. Is there anything here from anybody in the audience here that just looking at this brief part, we're obviously going to go through some more history and past medical history that would be a concern for you, especially when we look at diagnostic questions 1, 2, and 3 with these patients. Is there anything here that anybody would like to comment on or has any issues with? Again, my big thing when I hear anything like this is when I see burning pain in both feet. Obviously, when you see a bilateral neuropathy, you start to look at things other than just spinal in origin and add in there. You start to look at some of the different things that can cause neuropathy, ranging from drugs, chemotherapy, nutritional deficiencies, compressive lesions, a lot of different things. But you start to get your radar going when you see it bilaterally in both feet, especially in a 48-year-old. Further on with the history, there was a gradual onset of these symptoms over the last months, no history of trauma. He had had a few episodes of back pain in the past, but nothing major. Never felt anything in his legs before this. Again, he had presented to his podiatrist before for the injection. When that did not relieve him and it developed into both feet, his podiatrist referred him to a physiatrist after that. Physiatrist ordered an MRI of the lumbar spine and an EMG NCS study, which neither had been completed yet at the time of his visit at our office. He was referred to our office by his wife, who had been treated here for a pretty bad cervical radiculopathy case. So I find it's always a better patient when it's referred by someone who's had good success with you. There's just a little bit of trust right away that you have. So he was referred to our office by his wife. His past medical history, he was a big guy, 6'2", about 240, 245. He was not diabetic. He did not use tobacco or alcohol. He had a history of Crohn's disease, had a partial bowel resection in 2001. He's had some chronic diarrhea since, but not bad. He had been on high-dose cortisone before his surgery for a long while, trying to get the condition under control. So that was something that he was on before his surgical procedure in 2001. There's no history of cancer or chemotherapy for the patient. His father had a history of heart disease, malignant tumor of the lung, high blood pressure, hypercholesterolemia, chronic obstructive lung, and lower extremity neuropathy. So that was his father's history. Anything here that's of some interest to anybody with looking at a bilateral neuropathy here? Anything here that sparks some questions?
I just have a question, Kurt. You may have mentioned it, and I apologize if I overlooked it. Was the onset insidious, or was it a fairly short duration onset?
Pretty insidious. Yeah, he developed the heel pain and some of the back pain that went on over some months, and then he finally went into the podiatrist. But when he got the shot, it initially relieved him, but then it came back, and by this time he'd had an 8-month history of bilateral in the feet and that in there. So burning, 7 out of 10, neuropathic type pain in his feet. So it was a gradual onset, though. I think a key part too that we'll look at with this is what sparked me a little bit with this Crohn's disease and the partial bowel resection is nutritional deficiency. You know, we consider a B12 deficiency with neuropathy. So this had sparked my interest as far as to check his levels, and we did end up checking his B12. And then more importantly, they say, is to do the methylmalonic acid test. Methylmalonic acid reacts with B12 to form the coenzyme A for cell health. And if the methylmalonic acid levels are high, it's been shown to be a more sensitive indicator of a B12 deficiency. I'll give away a little bit of the future. He ended up being okay with that. He did not show any deficiency there, but you always consider something like that when you see neuropathy like this, as it could be a possible cause. Is there any relationship with neuropathy and genetics as far as with his father having a lower extremity neuropathy? Yeah, there can be. So that's something to look at too. But his father did have a history of tumor with chemotherapy and that with it. So, you know, his likely could have been related to that. And also his basically very poor health all around. But it got my radar up when I seen in the history that he had the partial bowel resection with the neuropathic type signs in his feet. So you always think of that with the surgery that he had. Actually, what we're going to find might be an important part of this story too is the high dose cortisone before his surgery. As we're going to find out, there's some things that are the precursors to these Tarlov cysts, and the cortisone may be a factor in this. And we'll talk more about that later. The patient did have a history of eczema. He denied at our first visit any history of bowel, bladder, or sexual dysfunction. He said no issues with that at all. Okay. And he's presently on warfarin. He had a pulmonary embolus in 2016. So he's been on blood thinners since the embolus in 2016. Not an exerciser, has a very sedentary job, an engineer at work. Does not have depression or anxiety, enjoys woodworking, been very limited now because he's unable to stand for a very long time at all. It markedly worsens his burning in his feet. And again, he was awaiting these reports from the MRI and the EMG nerve conduction study. So anything here that anybody has any questions on, or any points of interest with this patient?
Were his symptoms even when he was recumbent?
At this point, when he presented to our office, they were. When they first started, they were not. And it just markedly worsened when he would go from sitting or laying to sitting, and then worsen when he'd sit to stand. And then as it got worse, he could walk less and less without becoming worse and worse. So, but initially he had good relief when he lay down, but that quickly went away. We're going to talk in a little bit about the difference between when these cysts develop a ball valve mechanism, and that's when you can start to see where they don't have a position of relief. And we're going to talk about that in a little bit. But again, you start to get other things thought in your mind with the pulmonary embolism and that with it, is this related at all to this? So again, he's got an interesting history, I think, before this, where he gets a lot of thoughts going through your head. His initial presentation, you start to think, is there a compressive lesion? Is it stenotic? But it wasn't a classic stenosis either, and that with it. So he would have a lot of discomfort sitting, which, in my experience and the majority of experience with stenosis is that's a position of relief for them. So again, this one had my interest right away, that there was some things didn't fit here, and that with it. And so my radar was up with this history, as I think all of ours would be.
Yeah.
Kurt, this is Marcia. Just a quick question, because I can't remember now on the earlier slides, but who ordered the MRI and the EMG?
Yeah, a podiatrist, once his pain returned and burning, and it involved both legs and extended down the feet, referred him to a physiatrist who's maybe in the area. And the physiatrist had ordered the MRI and the EMG NCS. Yeah.
Okay.
He came to our office while he was waiting on getting that done, just because of his wife sent him over and thought we may be able to help him. So that's when he came over to our office while he was waiting for that.
Gotcha.
So again, what do we look at a differential? And these are just a partial list, but some of the big ones that we look at, diabetes obviously would be one. This particular patient was not diabetic, did not have a sugar issue. Nutritional deficiencies, B12. Again, we talked about the methylmalonic acid test as far as being probably the most sensitive to look at. And that in his case was okay. Again, he wasn't an alcohol user or a smoker. Autoimmune diseases you look at and that with it. So, do you consider Crohn's as being something like that? So, those are issues you look at. Infections, toxin exposures. He had no real histories of that. He did have the embolus, and again in 2016 the pulmonary embolus. And you look at medication side effects. Warfarin has been known in the literature to cause psoas bleeding, be a more femoral nerve neuropathy. This was definitely more S1 and that with it. So again, those are some of the things we look at. And compression neuropathies. Many of our spinal stenosis patients have issues with neuropathy in their feet, and it's a common condition that I see in my practice all the time. So again, compression neuropathies are there. And that's why, to look at the imaging, to look at the testing, and to see where this is at. And I did talk to him about, is this all necessary, or should we start a course of treatment? And the way his was worsening over 7 or 8 months so rapidly, I felt it was necessary to do the imaging and the testing, the EMG, NCS. So I'd be interested in anybody else's opinion on what they think, because I know everybody, we want to emphasize not rushing into doing these things, but I felt with his history, it was appropriate here. And I told him I felt like he should go ahead with it, and he did. So does anybody have any opinions on that, as far as, do you think it was jumping the gun, or do you feel there was enough suspicion here of other things to get a look at it?
Curious if anybody in the audience has any comments in that regard before I say what I think. I don't see any Q&A. David, you let us know if anybody pops in with a comment or a question or raises their hand. But I think you did
I will do.
spot on. I'm sorry?
I'll keep you posted if there's any
Okay,
input.
yeah, I completely agree with what you did, Kurt. Yeah, there are too many additional factors, you know, the Crohn's disease and like you said, being on cortisone, a family history of neuropathy. So yeah, and they can get really complicated.
And the
and-
rapid progression, I think.
Yeah,
Mhm.
and spreading from one to both feet, you got to be concerned.
I just saw with spinal stenosis, it's usually just such a gradual thing, you know, and for him to go from this to that in 7 or 8 months just seemed awful extreme, you know, and that I felt there was more going on here than a compression neuropathy from stenosis or something like that. And the whole sitting thing really didn't fit either. I mean, that sitting increased his neuropathic pain severely. So that just didn't make sense. So I'm glad you agree, but like I said, I know there can be some dispute sometimes, but I just didn't feel that this was a typical stenosis case by any means. Getting on to the examination, this made it even a little bit more stressful as far as, you know, just giving you some mixed signals. So, and something I remember greatly from the PSP class and Dr. Murphy talking about the neuro exam and, you know, one finding of upper motor neuron, you know, usually there's more than one, you know, and that in there, and that has to weigh in too. So I'll go through this, but it really was an interesting part of this patient. Blood pressure was a little high. Temperature was normal sinus rhythm. The lungs were clear. His lumbar range of motion was pretty good. And like I said, he really didn't complain much about his back. He had mild discomfort in flexion and extension. His hip range of motion was good. No issues that way. When I had him do some repeated extension and repeated flexion, it didn't change his pain. In fact, I mean, it didn't help his pain at all. It just aggravated it. And again, repeated flexion, you would expect if he could stay flexed, it would help stenosis, and that in there. Extension would aggravate it, but both positions aggravated it when I had him repeat it. He could walk on his heels and toes. When I tested his muscle strength in the lower extremity, all were 5 out of 5. He was able to hold all that good. So he didn't have any issues with muscle strength when I tested the lower extremity.
Can I ask you to clarify on that? Go back.
Yes.
When you said range of motion was normal but caused mild discomfort, did it cause mild discomfort in his lumbar region or the aggravation of the neuropathic pain?
It didn't aggravate his neuropathic pain when he flexed and extended or did anything, but it aggravated his back pain more. But anytime he was standing, his feet were bad. And that, so anytime he was in an upright posture or sitting, it would aggravate his feet. So, but yeah, it was more of the back pain was aggravated by flexion extension. When I did his upper limb stretch reflexes, they were 2+, symmetrical. Hoffman and Trommler's were both negative. Achilles reflex was 2+ and symmetrical. The patellar reflex was graded 3+ and symmetrical. Babinski's sign was negative. So now, you know, again, it's one sign, but Babinski was negative, but he was very hyperreactive to the patellar reflex. So again, that had me a little bit concerned there. What would be some things that we would be thinking about then with say a bilateral neuropathy and an increased patellar reflex and that with it? I'll tell you what my thoughts were then was I was thinking more of a thoracolumbar disc herniation or compression at that level that was creating a kind of a mix of an upper and lower motor neuron issue in that. So I tell you what I ended up doing, and it's one nice thing about being from a small town is I talked to the physiatrist and I said, he hadn't had the MRI yet. I said, can we collimate the MRI to include the thoracolumbar junction T10 on down? And they did do that for us without charging them anything extra. So I just wanted to make sure that there was nothing there with the thoracic spine creating a upper motor neuron lesion there. So
Great.
pinprick exam was normal bilaterally. His pulses were strong, no swelling in the lower extremities. His gait was normal. Romberg's was positive. He had issues with the eyes closed, holding his position. I think, which we commonly will see with the neuropathy in the feet and that in there. But he could walk okay. He had no steppage gait, no issues that way where he had trouble with inhibition or anything. So I felt his gait was okay. There was no nerve tension signs. We did straight leg raising and slump test. Didn't aggravate anything or set off anything that way for him. Does anybody else have any other thoughts about the hyperreflexia just at the patella, but not at the Achilles with a Babinski negative?
Hard to criticize your judgment here, Kurt. You were very thorough and appropriate in your thinking and approach. Yeah, that you know, calling the imaging facility, that's a great lesson for all clinicians, you know, calling the imaging facility and say, look, we need to make sure you capture all the way up to T10 so that we can find out if there's, you know, a lower cord compression, was a great move. So, yeah.
And 75% of them are thoracic disc herniations are T10 through T12L1. So I just at least wanted to collimate up that high. I wasn't too suspicious with the Achilles and Babinski, okay, but it still gets your attention. You know that it. I just was concerned enough to do it that way, and it turned out to be okay. There's a paper by Laura on thoracic disc herniation, and I always remember a quote in that paper. You don't see these get through the reviewers that often, but he says, "I'm convinced that it's not the diagnosis that or not the condition that is rare, it's the diagnosis that is rare on thoracic disc." And I thought that was a line that probably wouldn't get through a lot of reviewers, but it got through that one. So I thought that was interesting. And I think that's true of Tarlov Cyst too. I'm not so sure it's as rare as people say it is. It's just the diagnosis of it is rare, I think.
We went through you know, maybe I'll do it as a future case, a harrowing experience with my wife for 5 months of thoracic neuropathy.
Yeah.
And half of the physicians thought it was a viral infection induced neuropathy, not you know, herpes zoster shingles, but similar. But she also had a small herniation at T10 on the right, which coincided with her symptoms. Half of them thought that mechanical problem alone was the cause, but she had a viral infection, you know, 3 days before onset of all the neuropathy, and it was horrific. And it was a thoracic, and I think the ones who captured it best felt it was, you know, that the herniation probably created a diathesis there, a weakness, if you will, and then the viral infection just nailed that nerve.
Yeah.
Took 5 months, but go ahead. I'm sorry, I don't want to belabor the.
No, that's why we do this. I think those kind of cases are just so, you know, that's what makes it so much fun. But yeah, I had a thoracic disc lateral herniation that created a bulging abdomen. If you ever seen any of those case reports. And I admit when I saw it, I wasn't quite sure what it was, but Dr. Cox, I talked to him and he sent me some papers that show it. And when you lose the postural muscles, the nerve innervation from the thoracic spinal nerve, it just loses its tone. It bulges out. So yeah, it's get some interesting stuff.
Yeah, my wife had that. Yeah.
I did some instability tests, prone instability and active straight leg raising, and were both negative. Very tender to palpation over 4-5 and L5-S1 bilaterally. The SI joints were tender also in there, and with posterior P-to-A pressure and that with it, but it did not increase anything in his lower extremities as far as the feet. After the exam here, we discussed possible diagnoses. I confirmed with him this. I felt it was necessary to do the MRI and EMG NCS testing. How about diagnostic question number one? We always talk about, are there red flags here that we need to really be concerned about, and that what does everybody think as far as what are they thinking after the history and physical? Are there things that pop up in your head that we need to be aware of?
We've got Ali Hackett indicating night pain.
True. Yeah, I would agree. And I think, you know, to me, if it was a tumor spine wise and that in there, I think the back pain is going to be more severe than just a neuropathy in the feet. But anytime you got night pain, definitely, you know, it's something to think about, you know, in that with it. So yeah, I'd say that would be in our realm right now. And I think another reason to do the imaging, you know, in that with it, just with the way it was starting to affect his sleep and like Marcia said, the rapid progression. I think you got to find out why. And thank God in this case we did with him, because when it started to go south, it went south pretty quick. Diagnostic question number 2, you know, as far as the, you know, what's our diagnoses, what's going on? Can there be some joint dysfunction here? Sure. But obviously that doesn't explain all the symptoms like this here. You know, it's definitely a classic neuropathic type pain. We just got to figure out, you know, what's causing the neuropathy. Diagnostic question number 3, he really did not have, you know, fear avoidance, anxiety, stuff about it. He was naturally concerned, but he didn't really show anything like that. I thought of this when I was preparing this. I said diagnostic question number 3 ought to also include delayed treatment from people that have confirmation bias. They're like doctors that don't want to, if they were trained that Tarlov cyst meant nothing, they don't keep up on the literature and they don't want to be told anything different. I mean, when you can tell somebody that they have urinary urgency and they still don't consider the Tarlov cyst, I mean, I think that's that's part of diagnostic question number 3, how stuff gets slows down healing, slows down diagnosis, slows down everything. So, but as far as classic things from the patient, I don't think he was having any issues that way. This is the results of the EMG and nerve conduction study. Mild bilateral L5 and S1 radiculopathies, mild generalized peripheral neuropathy, sensory and motor, distal more than proximal, primarily axonal. The father had neuropathy and the patient has a history of Crohn's disease and pulmonary embolism. That was the conclusions on his EMG NCS report. And I don't think this is a forum to really get into the details of the report, but these are the conclusions that they found when they did the EMG NCS. And then I'll show you also the MRI. Again, when they start off at the top talking about the spinal cord, different stuff like that, bones and alignment. Again, in a 48-year-old, I'd say a lot of normal aging changes, as we like to say. Again, in the spinal cord, it says conus terminates normally. Incidental node is made of a Tarlov cyst in the sacral region. So this is what I see in a lot of my reports. So again, we're going to talk in a little bit about when is it important and when isn't it. So we'll talk about that as we go. Again, if you read through, I'm not going to read them to you and bore you, but if you read through from L1 to L5 S1, you know, nothing severe where there's a lot of stenosis. And I'll show you an actual sagittal view. I'm not going to show you all the views, but he doesn't have a lot of stenotic change in that in his spine. Basically, a lot of normal aging changes for a 48-year-old male who's overweight. Anybody have any issues, or have you seen those in your MRI reports about Tarlov cysts? I mean, I think it's a very common way that they express it, and that with it is just an incidental node is made of it. There's the sagittal view on the MRI. You can see his spinal canal is pretty well maintained. The 48-year-old, his disc heights are decent. Not a lot of ligament and flavum hypertrophy. He's really not bad. And again, if you look down by S2 down there, you can see the Tarlov cyst. He does have them bilaterally, and I will show you the sacral MRI later that will show it on both sides. So that's the Tarlov cyst. This isn't an exceptionally large one, but as we see in the literature, large or small, it isn't necessarily mean whether it's symptomatic or not. So again, the larger they are, the more potential, but it doesn't mean everything. So we can see this one here. But everybody agree, though, the stenosis central in the spine, and when you do the lateral too, it's really not bad. I mean, it's decent for a 48-year-old here. Again, by the time we got all the results back, it was about 3 weeks after his initial visit, and that in there, due to the MRI being pretty clean, I was concerned about the Tarlov cyst, But again, in his initial history, he had denied any changes with his bowel or bladder or sexual dysfunction. But with the Tarlov cyst there and the rapid progression of the neuropathy, I again asked him about his bowel or bladder. And I specifically mentioned urgency with it being one of the more common complaints. What we're going to find with a Tarlov cyst is it forms at the junction of the sensory root and the DRG. And so it's mainly has sensory findings first. So a sense of urgency with urination is very common to be the first sign, and then it can develop as it grows larger, creating motor signs. So I asked him about specifically urgency. Did he have where he had a hard time when once he had to go, he had to get there quickly? And he said it had been an issue for about 6 months or so for him, and it was getting worse. But he did not relate this to his spine. And I think it goes to, I've thought to myself, was I a little too dismissive during the history? It's easy to say, do you have any bowel or bladder problems? But should I have been more specific? But not knowing he had the Tarlov. But once I know he had it, I think it's important to maybe pin him down a little bit more and get more specific, because as these papers discuss at the end, it's not a comfortable subject for people. And a lot of neurosurgeons don't even ask about it. A lot of chiropractors don't ask about it. A lot of PTs don't ask about it because it can be an uncomfortable subject. So I think it's very important with any of these cases when you see a Tarlov cyst to really button down and talk more about bowel or bladder sexual dysfunction issues, because it's such a common thing with these problems. Because what areas is it most common at? It's the most common areas is at S2, S3 because of the hydrostatic pressure being down there. So always ask about it, always pin it down if you see the Tarlov cyst. And again, we had done the B12 deficiency testing with him after this appointment, and he did show up fine with that. There was no evidence of that. So I guess, does anybody else have similar experiences? I think when you're going through the bowel and bladder, sometimes we can be guilty of rapid fire questions where we're not really stopping, pausing, and making sure that it's not an issue. And I think this was a case for me where I should have hit it harder at the beginning, probably.
And perineal numbness is saved me twice in practice. Just asking about that.
Yeah. Yeah. And we did talk about that with him too. And he said he didn't have any of that. So, and he wasn't having any trouble with bowel control, but definitely had the urgency. He said, I get to where I barely make it, and that, and as you'll see in the next couple of weeks, he had a couple of accidents where he didn't make it. So again, it was progressing pretty rapidly, and we'll see why in a little bit on what happens with these cysts over time. I set up a consult with a neurosurgeon. He lived west of me, almost on the Indiana border. So he wanted to go to a surgeon over that way. I've used him before. I had a myelomalacia case a year or so before that he did a great job with. So I sent him there. And I also set up a pain management specialist for a possible aspiration. As we'll talk about, it's a very common way to treat these if they're closed valve, and that with it. During the wait for the surgical consult, the urinary urgency was increasing rather quickly, and the patient did have an accident or two. So it was getting pretty serious while we were waiting for this. After reviewing the literature, I ordered a sacral MRI because they said that's important before they do surgery or aspiration. So we did order a sacral MRI. It wasn't hard to get it approved with the urinary urgency going on. I sent a letter to the neurosurgeon before the appointment explaining the worsening urinary urgency and the finding of the bilateral Tarlov cysts. And all he wanted to talk about, as you see in his report, was the L5-S1 neuropathy. The Tarlov cyst is at S2-3. He didn't feel it had anything to do with it. So I started to worry that did he not see the note that I sent along with the patient, or did he not read it and that with it? So I sent him another letter with some of the maybe I overstepped my bounds. I put some research articles in there, some links, and I just said, with this thing being at S2-3, could this be the trigger for the urinary urgency? And I never got a reply back. And by that time, I had set up a second opinion with a neurosurgeon that I use at Ohio State, and he understood the urgency of the case, and he got me in right away and ended up operating on the patient. But because by that time, like I said, he had multiple accidents where he couldn't hold the bladder. But again, did he see it and not think it was important, or did he just not read, the letter to me? That I have no way of knowing. But this was his report back to me, just that he felt it was, to go ahead and go on gabapentin for the neuropathy and follow up with chiropractic or podiatrists and that in there, even though this guy had urinary urgency. So, yeah.
Did you, did they make any comment to you about the relative size of the Tarlov cyst in terms of, whether it was relative to all the ones that are found, small or large or medium? Did they make any comment as to the relative size of it or no?
He did not, no. And generally they talk about large being greater than 10 millimeters and that with it. So, and this one was in that range, but I've seen some, if you go through the literature, there's some absolutely massive ones where they break through the sacrum and they get into where they think they're adnexal mass in the front, in the pelvis, and they're actually a Tarlov cyst that has just grown huge. But what happens with these cysts is that the basic root cause of them looks like it is increased cerebral spinal fluid pressure, so intracranial hypertension of the cerebral spinal fluid, and so that cerebral spinal fluid gets forced out. That pressure is highest the more caudal you'll go. So that's why they're most common at S2, S3, down in that area there. What happens is that just like with a vascular aneurysm, when the high blood pressure is there and it creates damage to the walls, over time, that'll create granulation tissue in there. And that's what ended up happening with these cysts, is they'll be small, and then about the fourth, fifth decade of life, they start to develop that granulation tissue in there, and it creates like a ball valve. It allows the cerebral spinal fluid to come into the cyst, but it doesn't let it get back out. And then the cyst starts to really grow. When you get these large cysts, that's when you start to see the rapid changes, the motor changes and the sensory changes. And like in this patient's case, it becomes a valve cyst. Things start to go south in a hurry. So I'm going to talk a little bit more about how they get started and what some of the treatments are short of surgery. But this was his particular case here. There's a sacral view there. You can see the bilateral cysts there at S2 on both sides and their size and that with it. So that's after the sacral MRI. That with it. There was some bony erosion on these already. The surgeon talked about that when he got in there. So they do create some bony erosion. And like I said, the bigger they are, they can tend to get into the motor roots too, not just the sensory roots. And that's when you'll start to get loss of control of the bladder or bowel, those kind of changes like that. How do they affect L5 and S1? Very commonly, when you look at the literature, that increased pressure may not be a cyst there, but it's created more flow into those nerves and can irritate the nerves. So you'll get sensory changes even up as high as L5 from an S2 Tarlov cyst. So it fits the whole picture, but you got to know what you're looking for. And the surgeon was, looking more at L5 S1 radiculopathy than what he was looking here, figuring that can't be caused by this, but it can. Any questions on that with the sacral MRI? I have a brief comment from the neurosurgeon who was nice enough to, I think John and David and Mark said this would be a good point too. I got a really good relationship with a neurosurgeon over the years with some pretty difficult cases. And it's just really nice I have his trust now, where if I call him, he'll get him in right away or get somebody in right away that he trusts that I won't abuse the privilege and get him in. So I think it's important for all of us as primary spine practitioners to have that ability to establish a relationship where we can do that, because so many of these cases, like I didn't want to wait 6 or 8 weeks to get this guy in with the way things were going. So I think it's important for us as PSPs to establish those relationships and make sure that we can do that if we need to in a hurry.
Kurt, that's a great point to segue to Ali Hackett's question, which she asks, what recommendations do you have for developing good referral sources for surgery, aspiration, pain management?
Mm-hmm. Yeah, it's just a lot of legwork and time, I think, and some of it trial and error. I think the communication that you have with them, and whenever I refer to a neurosurgeon, I don't run off notes like I tend to write like a 1-page letter explaining my findings, what my suspicions are, what we, how long we've treated, and just to give them a heads up that way. And I don't know, I think sometimes if you just, print off a report off your computer, I don't even know if they want to look at that. They want a summary of what you did, what your exam findings were, and why you're sending them to them, I think. So that's what I've done over the years. And some people are interested in relationships, some aren't. And I want to find somebody that I'm comfortable with and confident with. And I've got that with 2 now, and I use them. I feel comfortable with them. I think they're conservative on their surgery and that with it, but I don't think there's any magic elixir on that with it. I think you don't want to be too pushy, because I think that'll scare them away. But I think you just want to be very professional and very communicative. I had faxed him a note after this guy's surgery, and he actually called me on the phone, and he had my number, and he called me to tell me how the surgery went and everything like that. So I can't say that's common, that's rare, but this guy is just that kind of guy. So I can't say I have any magic elixir, though. I think it's just do the right thing for a long time, and eventually, you gain the trust of the surgeon. So I found myself, it's easier to gain the trust of these specialists than it is sometimes the family doctors. I think they're more aware of what we do, and I think they're not as afraid of it and that with it. So I found, you just have to find 1 or 2 that will listen to you, and you can get referrals, like in this case where I felt it was pretty urgent that we get this guy looked at.
I would just add, I'm really glad you emphasized the communications piece, because we have heard directly from neurosurgeons that they just really want concise information that summarizes things neatly for them.
Yeah.
But I also think your skilled manner in managing this whole case was a part of it, and you demonstrated your complete competence in this, and that is what helps form those relationships. So.
Yeah. And yeah, you really have to fight for your patient, because, like we talked about earlier, if, with this PSP model, you're not done with your patient when you refer them. And that's what's so beautiful about it, and that is that, you're in charge of their care, just like a hospital is in charge of somebody's care in the hospital. You have to make sure they get to the right place at the right time for the right reason. And I think that's, where we can make such a contribution, to this, and that with it. So again, I've showed real quick, again, Dr. Grossbach after I had sent him over, he had sent me a text and just said that he agreed with me with the urinary urgency and where this was. He did the surgery, and the neuropathy improved 75% from the surgery. He still has occasional numbness and tingling if he's on his feet too long, but it's not that hard burning anymore. His urgency did clear up 100%, which I was most worried about when it got to the point where he was losing control. Sometimes I was just worried that there was going to be permanent damage, but he got back 100% the urgency, or the bladder control. And like I said, the neuropathy is not 100%, but again, there's a time issue. If we had seen him maybe a little bit sooner, but maybe we wouldn't have gotten as test happy early on either. But the fact that it improved 75% is a great result for neuropathy. So he's much more comfortable. He can do his woodworking, and he can walk and stay on his feet for a good amount of time. So he was happy, very happy with the results. This was a text I got from the neurosurgeon the night of the surgery. Everything went good. Found the cyst under a thin layer of sacral bone. Again, it eroded some of the sacral bone, fenestrated them, and removed the cyst wall. The ventral part of the cyst was the S2 nerve rootlets, obviously left that part alone. Then they put fibrin glue in the space to make sure that the cyst doesn't reform. Okay, so they put fibrin glue. The other method is cyst aspiration. And the guy that's founded all that, and it's really done more than anybody, is Dr. Murphy in Toronto, Canada. And he uses a 2-needle technique, puts one in deep, and then he puts one in superficial to let the air come out, and then he aspirates it down, and then he secretes back in fibrin glue and that in the area there to make sure that it doesn't fill back up again. You'll see from the literature that I shared with you at the end of the presentation that he's had a very good success rate with cyst aspiration. in closed valve cyst. If it's an open communicating cyst, what the smaller ones are, then you don't want to do cyst aspiration. It won't work. So you only want to do it with a closed valve cyst. This is Dr. Grossbach's response the night of the surgery. And I got this from the patient 3 weeks post-op. He sent me a text, nice text, and healing up nicely. All the major stuff is gone. Minor periodic tingling in the feet, sleeping good, pain-free, along with the urgency to go is gone. So he was very appreciative of it, because he was really depressed when he came back from the first neurosurgeon, telling him that it had nothing to do with the Tarlov cyst. And again, you have to kind of repair the damage and move on. But he was very comfortable with the other doctor at Ohio State. And like I said, it's very comforting feeling as a practitioner to have someone like that, because, you know, when you need it, you need it. And you don't want to wait 6 or 8 weeks, especially in this case, you know, because you don't know if permanent damage could have happened over that length of time.
I think a key takeaway here, Kurt, is your confidence in your own clinical judgment versus deferring to that first neurosurgeon, which I think, you know, I know some PCPs who would have done that, just deferred to the opinion of the neurosurgeon. And this patient, I'm sure, is extremely glad that you had sufficient confidence in your own clinical judgment to proceed forward.
And I think I'm not trying to toot the horn, but I mean, between my mentors, Dr. Jancy and Dr. Cox, and then the PSP program was such a great thing for me, along with the orthopedics. But you know, when you can do the good examination and you keep up with the literature, it's such a comforting feeling to go into work. But it also gives you the confidence to know that, you know, not everybody's out there because they're got neurosurgeon behind their name doesn't mean they know everything. So, you know, you got to stick with what you see and what you find, because we're all guilty of it in our professions. You know, they're so used to seeing what they see that they don't look away from it sometimes. And we have to be careful of that as chiropractors too. Any other questions on the management of this? And one way to find out if it's a closed valve is the size obviously becomes an issue. If it's rapidly progressing, usually an issue. The other thing is you can do a contrast MRI. If the cyst fills up slowly, it's likely a closed valve. And if it fills up quickly, it's like an open valve where you don't want to do the cyst aspiration. So that's your main decision on, should I try a cyst aspiration or should I do surgery, you know, on it, especially when, like I said, they're getting these harder neurological signs, called equina signs.
We do have a question from Christopher Webb. I may have missed this. How can we tell if it's a closed valve versus an open valve cyst? Yeah,
the one way is that MRI with contrast, and that with it, and then you also look at the size of it is a good indicator. And then if they're starting to get some motor signs, usually it's more of an indication as a closed valve. But the best objective one is to do an MRI with contrast. And then when you inject the contrast, if it fills up slowly, it's likely a closed valve, which you can be a good candidate for a cyst aspiration. Always ask the person how many times they've done it, because Dr. Murphy in Toronto, and I have those references at the end, Dr. Murphy in Toronto, he has a case report of over 1,000 of them. He gets people from all over the world to come to him, but he uses a 2-needle technique and has done a bunch of them. And again, it's like any surgery, you know, there was just an article came out a couple of weeks ago about the learning curve from Nancy Epstein on back surgeries. And some of those were like 50 operations for some of the more complicated ones. It's like, I wouldn't want to be in the first 25 then. So I think you want to get somebody that ask them if they've done them before on that, because it's not an easy area to get at.
Another follow-up question from Ali. How much time passes before an open versus closed valve cyst fills up with contrast MRI?
Yeah, I don't know the exact time on that. It's in that paper on there. They don't really talk about a time. They just call about slow fill and fast fill. I don't know that, but I'm sure I can review that paper, and I have those references in there and see. I'm not sure what the exact time frame is on that slow and fast fill though, and that with it. But In
And
my
then,
mind,
yeah,
if
go
the
ahead.
patient, like my patient, was progressing rapidly, I, to do too much with that, I was pretty sure it was a closed valve because of the motor signs that they were starting to get.
And then while we're in this Q&A segment here, just a tangential question from Jeff Scher. First, he's heard of fibrin glue and wonders if this might be appropriate for the rare symptomatic hemangioma.
I haven't heard it used that way, but yeah, I assume be a similar purpose, but I have not heard it used that way myself. So, one of the other tests for that, like I said, it's increased intracranial hypertension is the big thing here. And what they found with this is they're starting to treat these now with stenting on the transverse sinus, the venous sinus in the brain. There has to be a pressure differential there between the CSF and the venous pressure. And if those get stenosed and the venous pressure goes high, then the pressure on the CSF has to go higher to make that grade go back to the vein. So they're starting to look at doing stenting of the transverse sinus in the brain to treat Tarlov Cyst, lesions here. So there's a lot of stuff. I have it all in the notes. 45 minutes or an hour isn't enough to cover it all. Connective tissue disorders are also a risk factor with these. Ehlers-Danlos, Marfan's, those type of things are a much higher risk factor for Tarlov Cyst too.
Is there a heritable component? Is there a possibility his dad's neuropathy was an undiagnosed Tarlov Cyst?
Yeah, there is because of whether it be a genetic soft tissue disorder or what they look at is that permeability of that membrane between the dorsal root and the nerve root, and that's different. Females are 70% of these symptomatic Tarlov cysts, so there's a female component to it. So there is some genetic components that play a role. I think there's no doubt about that and that with it. So I think that is a factor. So obesity is very big on it with it too, because they feel that it increases the venous pressure. So then the CSF pressure has to go up to allow that gradient so the CSF can drain into the vein. And then, so they say that's a big factor with it is obesity too. So lowering weight, looking at those lifestyle factors is a big help for lowering hydrostatic pressure, intracranial pressure, which in fact will help with the Tarlov cyst.
While we're on the discussion of correlation, also another question from Christopher. Is there a known correlation between Tarlov cysts and Chiari malformations?
There is. There is. It is one of the risk factors in there. And again, I think you look at that upper brainstem and upper cervical spine as a possible choke point, for CSF. So again, yeah, that is listed as one of them. I think it's in Dr. Hewlin's some of his papers. He talks about that. So it is a factor. Yes. They talked about to do a diagnosis for hypertension, it has to be over 20 millimeters of pressure. They do a lumbar puncture, or sometimes they'll do the drug acetazolamide, which is a diuretic. If that relieves the patient, then it's a sign of the intracranial hypertension. So those are things. We talked about cortisone earlier. That's a big cause of intracranial hypertension, long-term cortisone use. So again, could that have been a factor with all the cortisone use he had with his Crohn's? So I've been in talk with the patient, explaining to him, because I know more than I did 5 years ago when he had this, as far as if this does start to return for him at all. We're going to look at those things, testing the venous pressure, testing cerebral spinal fluid pressure, and seeing if there's something we can do to get at the root cause of it. But so far he's been good. So, but he's aware of it because I'm aware of it now.
Yeah.
The cyst actually forms between, if you look at this slide, between the endoneurium, which is around the individual axon, and the perineurium, which is around the fascicle that's inside the nerve root. So that's where the cyst actually, the cerebral spinal fluid leaks through, and that's where the cyst actually develops. That was a good slide just to kind of show where it's at. Dr. Murphy has a great network for cyst aspiration. I had a doctor that we had trained in Cox technique. His wife, he sent me everything she's had, and it really looks suspicious. She had a really large Tarlov cyst. And so I told him to call Dr. Murphy, and Dr. Murphy actually called him back personally and set him up with somebody. He was in Western Canada. This guy, and Dr. Murphy's obviously in Toronto, over here more by Detroit. And he sent him to a doctor out there for cyst aspiration, his wife. So Dr. Murphy would be a good source, if you have a patient that's considering cyst aspiration with a Tarlov.
Now, this has been great. I want to be respectful of everyone's time.
Mhm.
Yeah, David, we'll have to see. Dr. Olding has a ton of additional information in the slide presentation about Tarlov cysts that we just didn't have time to really get into. I really think he hit the high spots for clinical practitioners to incorporate this information into how they evaluate a patient. But if there's a way we can include the PowerPoint slides that were not covered in the recording, David, that would be great. And Kurt, I want to thank you so much. This was really fascinating and a wonderful example of working through a case and then making sure you follow through with everything that you found.
Thank you. It was it was an interesting one. I think it's important that we're aware of it.
Yeah, absolutely. Absolutely. Any final questions? Yeah, you got a lot of thank yous in the in the comment section.
Okay, good.
So it's been a pleasure having you on with us, Kurt, and we really appreciate your sharing your expertise here.
All right, well, thank you for having me. I enjoyed it, and it was fun to prepare for it.
Yeah, great. Yeah, it's a wonderful exercise, isn't it?
It is,
Yeah.
and you learn a little more every time.
Yeah, absolutely. Absolutely. And the process that you go through helps you with every other case too.
It does. It does. I learned a few tidbits, and I didn't edit that great, but better to have too much than not enough, right?
Yeah, absolutely.
Yes,
No, that's
excellent
okay.
presentation. Excellent.
Yeah,
Thank you.
really, really good, Kurt. We really appreciate it. And thank you all for joining us today. And we hopefully will see you all next month. But
Thank you,
thanks
everyone.
again, Kurt.
Thank you.
Thanks so much.
Thank you, Kurt. Bye-bye.
All right,
Bye.
bye.